Treatment of tuberculosis requires a comprehensive step-by-step approach that begins with a thorough initial patient evaluation, followed by prompt initiation of pharmacotherapy, supportive care measures, and close monitoring. Initially, the patient should undergo a complete diagnostic workup that includes a detailed clinical history, physical examination, chest radiography, as well as a sputum study. That could be like acid fast bacilli smear and culture, as well as nucleic acid amplification tests. Laboratory investigation should include baseline liver function tests, renal function panels, complete blood counts, like CBC, and where available, the vitamin D levels and HIV testing. In patients with significant respiratory distress or hypoxemia identified by an oxygen saturation below 92% on room air, supplemental oxygen therapy should be considered immediately. A baseline oxygen saturation level is established using pulse oximetry. If SpO2 is 92%, oxygen supplementation should be initiated at 2 to 4 liters per minute via a nasal cannula and titrated to maintain SpO2 greater than 94%. The clinical assessment also includes evaluation for potential extrapulmonary involvement, which may require additional imaging, such as CT scans or MRI, depending on the organ system involved. In terms of respiratory control and supportive respiratory care, patients with suspected or confirmed active pulmonary TB should be isolated in an airborne infection isolation room with negative pressure to prevent nosocomial transmission. All healthcare workers and visitors should adhere to these airborne precautions by wearing N95 respirators. For those patients who exhibit signs of respiratory distress, oxygen therapy must be managed carefully. Begin with low-flow oxygen therapy at 2 to 4 liters per minute via nasal cannula and monitor the patient's respiratory rate, work of breathing, and oxygen saturation closely. If the patient's respiratory status continues to deteriorate, escalate to a simple face mask or a non-rebreather mask delivering 6 to 10 liters per minute, and in severe cases, consider non-invasive ventilation like CPAP or BiPAP, while ensuring that infection control protocols are strictly followed during aerosol-generating procedures. Should the patient progress to severe respiratory failure, mechanical ventilation in an intensive care setting may become necessary. Pharmacological treatment for TB is typically divided into 2 intensive phases, or I guess it's divided into 2 phases in general, like an intensive phase and a continuation phase. During the intensive phase, starting with that, which generally lasts between 2 months, the recommendation is a regimen that consists of a combination of 4 first-line drugs administered once daily. The regimen includes isoniazid, INH at 300 milligrams daily, accompanied by pyridoxine, which is vitamin B6, at 25 to 50 milligrams daily to prevent peripheral neuropathy, rifampicin at 600 milligrams daily, and pyrazinamide dosed at 25 milligrams per kilogram, typically resulting in a dose of approximately 1,500 to 2,000 mg daily, adjusted for the patient's weight. It's always on the patient's weight. And ethambutol at 15 to 25 milligrams per kilogram daily as well. The medication should ideally be administered with food because you want to reduce that gastrointestinal upsetting of the stomach, and the patient should be counseled on the importance of adherence to prevent the development of drug resistance. Monitoring during this phase includes regular LFTs every 2 to 4 weeks to assess hepatotoxicity and ophthalmological ophthalmologic examinations as well for ethambutol-related visual changes and clinical evaluations to gauge the patient's response to therapy. Following that intensive phase, the continuation phase is generally prescribed for an additional 4 months, during which the treatment regimen is streamlined to isoniazid and rifapentine, continuing at the same dosages, INH at 300 milligrams daily, and pyridoxine 25 to 50 milligrams daily, and RIF 600 milligrams daily during this phase. It remains essential to monitor adherence, evaluate for drug-related adverse effects, and assess the patient's clinical progress through periodic sputum cultures and imaging studies. The transmission from the intensive phase to the continuation phase should be based on documented clinical improvement, radiographic resolution of lesions, and conversion of sputum cultures to negative. In some cases, treatment duration may be needed for extended periods, particularly in patients with extensive pulmonary involvement, cavitary disease, or immunocompromised states. Throughout the entire treatment process, additional supportive measures are critical to ensure optimal outcomes, such as nutritional support should be tailored to the patient's needs. Patients with TB often benefit from a high-calorie, high-protein diet enriched with fresh fruits and vegetables, whole grains, and lean proteins to help combat the weight loss and malnutrition that frequently accompanies this disease. Specific nutritional supplements such as vitamin D, 800 to 100 IU daily, and multivitamins may be indicated, particularly if laboratory tests reveal deficiencies. Moreover, adherence to support strategies such as directly observed therapy should be implemented to ensure that the patient takes the medications as prescribed, reducing the risk of relapse or drug resistance. Regular follow-up visits are critical for reassessing respiratory status, monitoring for potential side effects of both oxygen therapy and medications, and adjusting the care plan as needed. This comprehensive step-by-step will put the patient in the right direction when it comes to treatment-wise, just following what their body needs in general.